Hello and Namaste. Today I shall be describing on clinical features and investigations of otosclerosis. Otosclerosis is defined as hereditary localized disease of bone derived from the otic capsule, which is characterized by alternating phases of bone formation and resorption. In otosclerosis, the lamellar bone is resorbed and replaced by a woven bone of greater thickness, cellularity as well as vascularity. You can see here, this bone is a woven bone and this is a lamellar bone. The bone has to be lamellar in nature. The lamellar bone is replaced by a woven bone of greater thickness, cellularity and vascularity in otosclerosis. The new bone thus formed is spongy and more vascular in otospongiasis, and in the inactive stage or in the late stages, the bone becomes thicker and denser. Coming to the clinical features, how does the patient of otosclerosis present to us? Most common presentation of patient with otosclerosis will be deafness or decreased hearing or hard of hearing that usually happens bilaterally, which is gradually progressive in nature, occasionally associated with tinnitus. When the patient is having active disease or otospongiasis, the patient has tinnitus because of high vascularity of the bone. The disease usually is bilateral condition, but in 15% of cases, the disease might be unilateral. When the patient has stapedial otosclerosis, there will be conductive hearing loss. When the patient is having cochlear otosclerosis, the hearing loss becomes sensorineural. And in the case of mixed otosclerosis, that is stapedial plus cochlear, the patient will have mixed hearing loss. Before the onset of hearing loss, the friends or relative notice soft, modulated and monotonous voice of the patient. The patient usually speaks in soft and monotonous voice. This voice happens in all the cases of conductive hearing loss, but is more common in patients with otosclerosis. In case of sensorineural component or mixed component, patient will have loud voice. Vertigo is common in cochlear lesion, but sometimes tinnitus also might happen. So tinnitus might happen in active stage or in cochlear otosclerosis. The next symptom is paragusis villi. The patient hears better in noisy surroundings because in noisy surroundings people increase their voice intensity so that patient's speech discrimination becomes better. Here you can see the person have normal score percentage on speech discrimination in 20 decibel, but when the patient is having otosclerosis, you will have almost normal speech threshold in around 60 decibel. So when other people speak at around 60 decibel, the patient with otosclerosis can understand the speech. This is called paragusis villi, or the patient hears louder in the noisy environments or noisy surroundings. In tympanic membrane examination with otoscope, the TM is usually normal. Some textbooks explain that the TM will be mint-like, MINT, mint-like. We can see Schwarz sign or flaming pink blush. It is seen in otospongiasis or active disease, and it is seen in around 2 to 10% of the cases. You can see here, this is the flaming bird, which is pink. So this pink-like nature of the tympanic membrane can be visualized in patients with otosclerosis in early stage, that is otospongiasis. So this is due to pinkish hue of the promontory due to active otospongiatic bone, but it's not a true picture of all the cases of otosclerosis. In late stages, when the patient is having otosclerosis, there will be no pinkish hue of the promontory. Coming to tuning fork tests, in case of stapedial or conductive otosclerosis, there will be Rini negative, Weber lateralized to deaf ear, and ABC becomes normal. In cochlear otosclerosis, Rini will be positive, Weber shall lateralize to the better ear, and ABC will be decreased. In case of mixed hearing loss, Rini will be negative, Weber lateralized to the better ear, and ABC will be decreased. Gilly and Bing tests were carried out in the past, but they are not usually performed nowadays. When a vibrating tuning fork is placed over the mastoid and the external canal is blocked, in otosclerosis, there will be no change, but in either normal or sensory neural condition, the intensity will increase. You can test on yourself also. When the external artery canal pressure is increased by sacralization in Gilly test, in otosclerosis there will be no change, but in normal or sensory hearing loss, the intensity decreases. How to investigate for otosclerosis? Most commonly performed investigation for otosclerosis is Pureton audiometry. It shows low frequency conductive deafness. You can see here, this is the conductive component on the left side, and this is low frequency conductive component. It is due to stiffness of the tympanic membrane or stiffness of the middle ear. Characterized is a very commonly explained term in case of otosclerosis. It is seen in bone conduction at 2 kHz. This is deep at 2 kHz in bone conduction. Characterized is due to steppage footplate fixation. As the resonant frequency of the steppage is at around 2000 Hz, the dip occurs in 2000 Hz. The usual phenomena is 5, 10, 15, and 5 in 500, 1000, 2000, and 4000 Hz. That is the Carhar's notch. The patient won't have any problem in speech discrimination score when the hearing level is increased. It's almost 100% because patient is having only conductive component. Speech reception threshold, intensity at which 50% words are heard, is increased by the amount of conductive hearing loss. As we could see in the previous picture, the patient had normal speech reception threshold at around 60-65 decibel hearing level. The next investigation of choice is impedance audiometry. In impedance audiometry, there will be AS curve in around 40% of patients with otosclerosis because there will be fixation of the steppage footplate. The middle ear pressure will be normal, but there will be decreased middle ear compliance due to steppage fixation or stiff tympanic membrane or the ossicular chain. Other people have A-type curve. Therefore, having AS-type curve signifies there will be ossicular fixation. And if the patient is having A-type curve also, we cannot exclude otosclerosis. There will be absent stapedial reflex as there will be steppage fixation. CT scan of temporal bone, HRCT of temporal bone using 1 mm thick sections is useful to assess the labyrinthine windows and the cochlear capsules. There might be thickening, distortion, or obliteration of the labyrinthine windows. As you know, labyrinth is the densest bone in the body. The bone density does not go maximum. So the bone either might be thickened, distorted, or obliterated. In this picture, you can see hypodense, demineralised plaques, which is seen in fissula and Deafness region. This is the hypodense lesion, and this is the hypodense lesion. Therefore, there will be thickened part of the bone in otosclerosis that might be either distorted or obliterated, but the bone density will not increase. This is all regarding clinical features and investigations in otosclerosis. If you have any doubts, go through the textbooks. I hope this class was useful to you all. Thank you.